Hello everyone and welcome back to my playlist of pharmacology. हम respiratory system की drugs कर रहे हैं and today a very important group of drugs which are used to treat asthma. So asthma is a very common condition and it may be life threatening if there are severe attacks of asthma. So therefore it is very important to understand that what are the drugs and what are the armamentarium which are available to deal with asthma. तो फर्स्ट ऑफ ऑल तो आपको ये पता होना चाहिए कि एस्थमा है क्या. देखें, एस्थमा इज़ अ क्रॉनिक इन्फ्लेमेटरी डिजीज of the airways which is characterized by episodes of acute bronchoconstriction. So here is the problem. See, your trachea and then bronchi and then bronchiole, all the airway, it has to maintain a certain degree of patency ताकि इसमें से air easily flow करके और alveoli तक पहुंच सके. क्योंकि अगर एयर फ्लो में किसी भी तरह का ऑब्स्ट्रक्शन होगा तो आपके पास एल्वोलाई तक कम एयर पहुंचेगी, कम ऑक्सीजन एब्जॉर्ब होगी, कम कार्बन डाइऑक्साइड बॉडी से रिलीज होगी, ऑल दी सॉर्ट ऑफ थिंग्स. ओके, नाउ देयरफॉर इट इज़ वेरी इंपॉर्टेंट कि आपका एयरवे जो है उसकी एक फिक्स पेटेंसी मेंटेन रहे. अगर वो नहीं रहती और देयर इज़ ब्रोंको कंस्ट्रिक्शन, साइज छोटा हो जाता है आपके एयरवे सिस्टम का, देन दिस इज़ व्हाट वी कॉल एस्थमा. एक तो ये इसमें इशू है और इसका मेजर रीज़न ये होता है because there is chronic inflammation, so there is a lot of liquid production. So बहुत सारा mucus बनता है and that kind of blocks and clogs the airway. Okay, and therefore the patient experience shortness of breath, cough, obviously सांस उसकी उखड़ेगी, है ना, cough, chest tightness, wheezing, rapid respiration because airway block हो चुका है. So that's the main kind of definition thing of asthma. And then what is the pathophysio? Airflow obstruction in asthma is due to bronchoconstriction, which means constriction of bronchial pathway, airway का contract हो जाना, constrict हो जाना. So the size of the airway, for example, from this goes like this. So you see there is smaller lumen and then obviously less air passing through. Now it happens because there is contraction of bronchial smooth muscle, inflammation of the bronchial wall, and large amount of mucus being secreted. Okay, the underlying inflammation of the airway contribute to the airway hyperresponsiveness, airflow limitation, respiratory symptoms, and disease chronicity. ये एक बहुत बड़ा important है. Asthma is an allergic problem, and the airway responds in a hyper reactive manner. So the point is, when there is a stimulus which incites inflammation in asthma, the inflammation response is kind of very much exaggerated. So your airway is hyper responsive. Okay, asthma attacks may be triggered by exposure to allergens. Now allergens can be known allergens. For example, it can be pollen or dust or things like that. But many patients have unknown allergens. They don't know what actually initiate the asthmatic attack. It can be exercise, it can be stress, even extremes of temperature or any infection. So a person may be fine, but in case of respiratory infection, the attack of asthma are exacerbated. Unlike COPD, cystic fibrosis and bronchiectasis, which are separate set of respiratory disorders, asthma is not a progressive disease. It's usually not a progressive disease. इसका मतलब ये है कि ऐसा नहीं है कि आज कम asthma है, कल ज़्यादा होगा, परसों और ज़्यादा होगा. जबकि इन डिजीज़ में ऐसा होता है कि the severity increase because there is destruction of the lung tissue. लेकिन यहाँ पर ये है कि इट्स अ रिपेटिटिव डिसीज, ये बार बार हो सकती है. इट कैन बी पीरियोडिक, इट कैन बी साइक्लिक. सो ये अटैक्स बार बार होते हैं and therefore it can be life threatening as well. However, if untreated, asthma may cause airway remodeling, resulting in increased severity and incidence of asthma exacerbation or death. So, although the disease is not something like कि हर episode के साथ उसका severity structural changes of the respiratory system की वजह से बढ़ेगा, but the point is कि with very long term asthma there is some remodeling and the subsequent attacks can be severe than the previous attacks. So ये ज़रूर देखा जाता है clinics में कि अगर किसी को 10 साल से for example asthma है, the patient can have more severe attacks of asthma because of this long standing duration. Okay, now that's a very good diagram. I like this very much. It shows that this is the normal airway. Air enters from the nasal cavity and the oral cavity, gets into trachea and then into the airway. And look at the big lumen of the airway. It's a normal bronchial tube. But look what happens in asthma. There is a lot of secretion, a lot of mucus production, and the size of the airway. Look at the size of the airway. This is heavily inflamed bronchial tube, and the lumen gets so much smaller. So muscles of bronchi are tight and thickened. So these muscular layers are tight and thickened, and there is a lot of mucus production. And the overall effect is bronchoconstriction. So this is a very nice diagram to give you a very basic understanding of what happens in asthma. Now, remember the goals of therapy are not only to obviously address the acute attack, but also the long-term efficacy you need to obtain in these patients. So, drug therapy for long-term control of asthma is designed to reverse and prevent the airway inflammation so that the next attacks do not happen. The goals of asthma therapy are to decrease the intensity, frequency of asthma symptoms and prevent the future exacerbation and minimize any lifestyle limitations which are due to asthma, because when these patients, if you look at these patients, they are sometimes unable to do normal life works, and this is very, very disturbing disease. So remember, the goal should be not only to reverse the process, to prevent future inflammation, but also reduce the intensity during the attack. Because if the patient comes to you with an acute asthmatic attack, the first thing you would like to do is quick relief of symptoms. So you need to reduce the intensity. And then later you will think about कि कुछ ऐसा करेंगे जी फ्यूचर में भी इसको अस्थमा का अटैक ना हो, उसकी सिवियरिटी कम हो. Okay? So here is a nice table which tells you about the first line therapy based on the classification of asthma, which is presented in this column here. So if it is very severe and persistent type of asthma, what will you use? If it is moderate, persistent, mild, persistent, intermittent. So these are different categories of asthma, and these are the different drugs which are used as first line for quick relief of symptoms. So for example, if there is intermittent asthma, what is done is actually short-acting beta agonist, SABAs, they are used for almost all type of asthma for quick relief of symptoms. So if you see intermittent asthma, you use SABA. If you use mild persistent, you use SABA. Also in moderate disease, you use SABA, and also in severe disease, you use SABA. So SABA is a very nice agent for quick relief of symptoms in all categories of asthma. But remember, you must first know that what do we mean by intermittent mild persistent. So we call it intermittent asthma if there is less than 2 days per week episode of bronchoconstriction. So if the patient has like respiratory problems and the asthmatic attack lasting for less than 2 days per week, we call this intermittent. If it is more than 2 days per week but not daily, so for example Monday, Tuesday, Wednesday, and then Thursday, Friday are fine. So more than 2 days but not daily, so this is mild persistent. If it is happening daily on routine basis, moderate. And if it is just no gap and no rest, it is continual, and this is what we call severe. And then, when you do spirometry on these patients, or flowmetry on these patients, peak flowmetry, spirometry. So the findings are, for these two categories, it is usually near normal. We call near normal when the results are approximately near 80% of what is expected to be the ideal. So if the flows are about 80% of normal, we consider them near normal. Okay. If it is moderate persistent asthma or severe, then obviously the lung functions are going down, and the flowmetry and the spirometry test will show this. So 60 to 80% of normal and less than 60% normal readings in these two categories. So this is easy to understand. Okay. So quick relief of symptoms, I told you in most of them, actually all of them, you give short-acting beta agonists, but then you may add some alternative drug, which we'll talk about in a minute. And for long-term control, you don't need actually a daily medication for intermittent disease. For long-term control, you just stick to quick relief of symptoms. For mild persistent, you may give low doses of inhaled corticosteroids, ICS. And if it's moderate and severe, then you have to add a few other things. So you may add low-dose ICS and long-acting beta agonist, for example, or medium-dose inhaled category of corticosteroid for moderate. And for severe is severe, so you actually have to use high doses. So high doses of inhaled corticosteroids plus LABA. So these are the additions. So these are the additions to quick relief of symptoms. So very nice chart. Now, my point is, what I tell students, that when you are studying pharmacology, please read it from the perspective of pharmacology. So, for example, in medicine, we talk about what is the algorithm to treat asthma patients. So in this algorithm, we talk about if the patient come with this presenting complaint, you try SABA, for example. If symptom relieved, then you do this. If not relieved, you do this. If relieved, you do this. If not, you do this. So there is an algorithm. where you should know and you are taught that what is the armamentarium that you have to use to move on to the next step. But these gadgets are drug molecules, and these drug molecules are studied in pharmacology. So in pharmacology, usually they don't tell you the algorithms for treatment, so don't expect it in pharmacology lectures. But what you should understand in pharmacology lecture is you should understand the gadgets available. So you should know what is SABA, you should know what is ICS, you should know what is LABA. So their intrinsic characteristics are the goal for pharmacology lectures. Algorithms come in medicine, so expect the right thing in the right place. Okay, now let's talk about the gadgets that we have. So beta adrenergic agonist, and we want these because we want to mimic the sympathetic system, and if we mimic the sympathetic system, we know that sympathetic system in normal physiology dilate the bronchial muscles, so smooth muscles are dilated, and this is what we want to do. Therefore we use beta adrenergic, which is sympathetic channel, their agonist, so that muscles are dilated. Okay, inhaled beta adrenergic agonists directly relax the airway, and this is what we exactly want in an asthmatic patient: a relaxed and a dilated airway system. They're used for quick relief in all categories of asthma. We just noticed short-acting beta agonists have a rapid onset of action, 5 to 30 minutes. That's why they are called short-acting, and provide relief for up to 4 to 6 hours. Very nice. So they give quick relief. They are used for symptomatic treatment of bronchospasm, providing quick relief of acute bronchoconstriction. All the patients with asthma should receive SABA inhaler for use as needed. So as we go back to this particular table, all of them, they are recommended to use SABA if it's intermediate or moderate or severe or whatever category of asthma. Okay. However, monotherapy with SABA may be appropriate for patients with mild and intermediate, but if there is a moderate to severe type of asthmatic patient, we have to use something, okay, in addition to the simple SABAs, right? Direct-acting beta-2 selective agonists include albuterol and levalbuterol, and these agents provide significant bronchodilation with little undesired effects on alpha or beta-1 because they are direct-acting on beta-2. And this is what we want for muscle dilatation. However, they are not free from side effects like any other drug. The side effects include tachycardia because of their actions on the cardiac cells, hyperglycemia, hypokalemia, low magnesiums, and also there are skeletal muscle induced stuff. So skeletal tremors are also some of the side effects which are seen, right? So easy stuff. Now, so that was quick relief, right? SABAs for quick relief. Then long-term control. Salmeterol and formoterol they are long-acting. They are also beta-2 agonists, but they are long-acting, and their chemical analog albuterol, ये इन्हीं के basically chemical analog हैं, but they are long-acting. They have long duration of action, providing bronchodilation for at least 12 hours as compared to, you see, only 4 to 6 hours short-acting. These are long-acting. Use of LABA monotherapy is contraindicated, and LABAs should be used only in combination with asthma controller medication, such as an inhaled corticosteroid. ICS remain long-term control of the choice of asthma because it reduces inflammation, it cuts off the prostaglandin pathway, and if we look at a diagram, there is a diagram there. So if you, this arachidonic pathway is a must for you to understand. It gives rise at the end of the day to a lot of inflammatory mediators. You see, these are all the inflammatory mediators, leukotriene, C4, E4. They mediate inflammation, and because of inflammation, there is bronchoconstriction because there is a lot of mucus production, a lot of immune cells there, cytokines, many immune cells infiltrating there. You want to block this inflammation, and that's what inhaled corticosteroids do, right? If you block this pathway up there, then the downstream chemicals will not be produced. As simple as that. So simple stuff. But the take-home message from this paragraph would be that LABAs are not used alone. So if you look at the diagram here, nowhere here you will use LABA alone. So LABA always with something, such as ICS. LABA always with something. So you never use LABAs alone. Okay, long-acting, never used alone. Right. Some LABAs are available as a combination product with ICS. So now we have advanced formulations, easy. Adverse LABA, they are actually similar to what we saw in short-acting beta agonists because these are anyways beta-2 agonists. So side effects are the same: hypokalemia, hypomagnesemia, skeletal muscle tremors. We also use corticosteroids. ICS are, very important drugs to be used in asthma. They're a drug of choice actually for long-term control in patients who have persistent asthma. Corticosteroids inhibit the release of arachidonic acid, so they control the inflammatory system, as I just told you, explained in this diagram. Okay. Now, ICS therapy directly targets underlying airway because आप inhale ले रहे हैं इसको तो directly airway तक पहुंच जाता है, so सारा जो eosinophil और इनके inflammatory जो cascades हैं वो block हो जाते हैं, right? And it helps big time in reversal of the inflammatory edema. It's a very, very important agent for the treatment of asthma. How can you administer steroids? Inhalation. ICS is markedly reduce the need for systemic, because if you use systemic corticosteroid, there are like heavy side effects associated, but inhalatory directly ending up into the bronchi and doing their job very effectively. Now, patients with a severe exacerbation of asthma may require intravenous steroids. Sometimes this is also used if there is severe, and then obviously there will be adverse effects. Steroids are not free from effects, and oral or parenteral corticosteroids have a variety of potential serious effects, whereas ICS, particularly if used with a spacer, have few systemic effects, and understandably, reasonably understandable, because it is directly going into the respiratory system directly. और अगर आप systemic therapy दे रहे हो तो वो पूरे body में जाकर के पूरे systemic effects करेगा. All the effects associated with steroids will be seen here. So hyperglycemia, for example, hypertension, moon phases, Cushingoid features, all these things will happen with steroid therapy. All the side effects, okay? Now, these are the initial first line drugs. We used to call them the primary drugs, the initial drugs, including SABA, LABAs, and steroids. Now we have some, another class of drugs, and this is important too, because with the advent of there are so many advances in the biotechnology field, so new drugs are being coming, and we have now alternative drugs available for asthma. So these drugs are useful for treatment of asthma in patients who are poorly controlled by the conventional therapy. So conventional therapy is SABA, LABA, steroids, okay, and then they can be used in conjunction with the conventional therapy or with ICS only. Now let's see what are these. These are basically inflammatory blockers. So for example, leukotriene modifiers. So if you remember the initial diagram that we had a look at, these nasty molecules, they are nasty molecules. You need to block them. So for example, leukotriene B4, and these are all, if you are able to block these, then you can kind of put harnesses on the inflammatory speed. So leukotriene B4 and cysteine leukotriene, such as leukotriene C4, D4, and E4, they are produced from the 5-lipoxygenase pathway, and it's found in the cells of myeloid origin, such as ये molecule जो है ना 5-lipoxygenase, this is present in mast cell, basophil, eosinophil, neutrophil. So ये वाले जो सारे cells हैं, ये bronchi तक पहुँचते हैं at the site of asthma, and they produce all these things, right? Now LTB4, leukotriene B4, is a potent chemoattractant for neutrophil and eosinophil. So they are strong inflammatory molecules, ठीक है? Whereas the cysteine leukotriene, ये वाले जो leukotrienes हैं, they constrict the bronchial smooth. So deadly combination, you see. ये immune cells को बुला रहा है ताकि more inflammation हो, और ये तो साला खुद ही bronchial जो muscles हैं उनको constrict कर रहा है. So not good thing, right? So we have now some drugs to stop these nasty behaviors. So zafirlukast, for example, and montelukast, they are selective antagonists of the cysteine leukotriene 1 receptor. So they kind of block the production of these leukotrienes, okay? These agents are approved for prevention of asthma symptoms. They should not be used in situation where immediate bronchodilation is required, because that's what they will not do. Their action will take time to get away with the inflammatory effect. Immediate अगर आपको चाहिए ना relief, तो वो साबा यूज करना है आपने, short acting beta 2 agonist, okay? Their pharmacokinetics, they are orally active, so given orally, and highly protein bound. Food impairs with the absorption, so empty stomach. These drugs undergo extensive hepatic metabolism, xylitine and its metabolites are excreted in urine, whereas zafirlukast, montelukast, in the liver excretions. Obviously, there are certain adverse effects because they are metabolized by the liver, so it is understandable to get elevated liver enzymes, right? That can happen. LFTs may derangement. Other effects include headache, dyspepsia. Zafirlukast is an inhibitor of cytochrome P450 system, which means it will interfere with a lot of different drugs, right? Co-administration with drugs that are substrate of this enzyme system should be done with caution, okay? Then there is another drug called cromolyn. and it's a prophylactic anti-inflammatory agent that inhibits the mast cell degranulation. So one of the problem obviously for asthma is inflammation, and we are trying to block inflammation. We are trying to block inflammation by steroid, we are trying to block inflammation by leukotriene stabilizers and modifiers, and we are now also using a drug which is stopping the mast cell to degranulate, ताकि इसमें से जो अंदर सारा माल मवाद है dangerous inflammatory material वो न निकले. So that is cromolyn. Okay, हिस्टामिन नहीं निकलने देता ये, बिकॉज हिस्टामिन की वजह से फिर इन्फ्लेमेशन और ब्रोंकोकॉन्स्ट्रिक्शन. इट इज़ एन अल्टरनेटिव थेरेपी फॉर माइल्ड persistent asthma. It's available as a nebulized solution because cromolyn is not a bronchodilator. It is never used in acute attack, okay, or with the purpose of quick recovery. Quick recovery, still the mainstay is SABA, right? Then for beta receptor, we were using agonist, and now for parasympathetic system, we will use antagonist, because the job of parasympathetic system in the airway is to bronchoconstrict. So if you inhibit that bit, there will be bronchodilation. Okay. So ipratropium, for example, it's a short-acting derivative of atropine, and it is not recommended for routine treatment of bronchospasm in asthma, as its onset is much slower than that of the SABAs. So obviously they were used traditionally. अभी इनकी बहुत ज़्यादा जगह नहीं है management plan में. SABAs have taken over. Okay, that's the bottom line that you have to understand. Then theophylline is a bronchodilator that relieves airflow obstruction in chronic asthma and decreases the asthma symptom. It may also pose anti-inflammatory activity, but again, that used to be used. It has largely now been replaced with SABAs and LABAs. Okay, so that's basically it. And the last bit is the monoclonal antibodies. There are some antibodies developed. MAB, whenever it comes as monoclonal antibody, omalizumab, for example, it selectively binds to immunoglobulin E and try to inhibit the immunoglobulin E mediated inflammation in asthma. This leads to decreased binding of IgE to its receptors. Mast cells को उसकी खुराक नहीं मिलती. IgE works with mast cells, and therefore inflammation is inhibited. There are other monoclonal antibodies called mepolizumab and benralizumab, a few others which are interleukin 5 antagonists. So you are trying to block interleukin 5. Adverse effects include serious anaphylactic reactions, and they are pretty serious. And above all, this is very expensive, and it has to be given IV. It is very expensive, a lot of side effects. Therefore, they are not routinely used, and they are also linked to a few malignancies. So still the treatment is like SABAs, LAMAs, ICS, and leukotriene modifiers. So that's all about the gadgets that you have in hand to treat asthma. अब वो गैजेट्स किस तरह यूज़ करने हैं, कब क्या चीज़ उठा के आपने, कब चाकू उठाना है, कब चम्मच उठाना है, कब देगची में क्या डालना है, that's the algorithm, and that we do in medicine. Okay, but for now you now know the gadgets which are available for treatment of asthma. Take care of yourself. Have a good weekend.